So we meet again today. We're going to talk about respiratory tract infections. Our topic of discussion today is pneumonia. I am your presenter, medical licentiate, Mr. Mwanza. So, if you look at the screen there, there is a diagram that shows the respiratory tract infections that are common. You may take time to look at them depending on the site of the infection. That's why you make the diagnosis to say it may be tonsillitis or it may be sinusitis. We'll proceed to having the definition. So we define pneumonia as inflammation of the lung tissue. Okay? So with the current statistics that are around, with the epidemiologies, the prevalences that are there, pneumonia comes in to be one of the leading causes of death in children worldwide, not only in Zambia. Okay? So if we make an estimation, it kills about 1.8 million children every year. More than these other diseases like measles, HIV, and malaria. So let us look at the classification of pneumonia. So this classification is based on the anatomic forms, and also the part, when we talk about the anatomic forms, we look at the area at which the infection has affected. So the classification can be classified as in interstitial pneumonia, bronchopneumonia, lobular pneumonia, or lobar pneumonia. Let us look at the etiological pneumonias, so the bacteria in particular. So in the newborns, you know that the most common cause, it is B. streptococcus, it can be Klebsiella, E. coli, Enterococci, Pseudomonas aeruginosa, also Proteus. And those that are less than 5 years are Streptococcus pneumonia, Staphylococcus, Aedes staphylococcus, Chlamydia, Haemophilus influenza, Pseudomonas aeruginosa, also TBC. In older children, the etiology most is Streptococcus pneumonia, Staphylococcus, Haemophilus, Pseudomonas aeruginosa as well. When you look at a typical pneumonia, these most include the Legionnaires pneumonia, the Mycoplasma pneumonia, Chlamydia pneumonia. So when you look at the viral causes of pneumonia, the most common form, which is the most common form of pneumonia, we look at things like respiratory syncytial virus, RSV, influenza virus, adenovirus, and all other common viruses that are present. When we're looking at the common causative agents, the etiological causes of fungal pneumonia, this is where now we find the Candida album, Coccidioidomycosis, histoplasmosis, pneumocystic Gilovich pneumonia, which is PJP. And this PJP, this is the most common cause of pneumonia in children who are HIV and AIDS positive. Okay, it is responsible for most of the quarter death that may happen in neonates or infants that are HIV positive. So, WHO, the guidelines that we follow in Zambia here, they have classified it according to the severities of these pneumonias. Okay, so they can be very severe pneumonia, severe pneumonia, or it can be just cough and a cold. But it is important to understand the clinical manifestations on how these patients will present with, before even doing an investigation, something that will bring you or give you something that would call as a differential diagnosis. Often these infants or the patients will present with a history of an upper respiratory tract infection, which may be in form of stuffy nose or poor appetite. That further proceeds to having fevers, the fevers which will be accompanied by restlessness, and also respiratory distress with tachypnea. Also, we may talk of cough. If you do a physical examination, something that we'll look at as we further discuss is, you will see that there will be chest indrawings. Cyanosis, and also there may be refusal to eat and may present with another danger signs. There can be nuchal rigidity, which may also be present. Others will present with abdominal distension. When you do an examination, or if you do a physical examination, you'll find that these babies will present with cyanosis. When also you find that there'll be chest indrawing as they breathe, there'll be signs of chest indrawing. If you look at the nose, there'll be flailing of the arenas, which is on the nose. Also, you find that there's fast breathing, which requires tachypnea. When we auscultate these patients, during auscultation, we're using a stethoscope, you find that there's reduced vocal parameters. Also, you find that there are crackles on the affected side, because remember that the classification is based on the anatomic site where the pneumonia has affected. But also, you find that there's diminished breath sounds during the consolidation phase. Okay, so if you do percussion, you find that there is a dull sound. But let us also look at the main clinical signs of pneumonia, also in form of tachypnea. Those that are less than 2 months, you find that they are they will have greater or less than 60 respirations per minute. Those in between the ranges of 2 and 11 months, you find that they will be greater or less than 50 respirations per minute. Between 1 and 5 years, there will be greater or less than 40 respiration rate per minute. Below there, you can look at subcostal recessions. Here, this is where nicely you may appreciate the chest indrawing in these patients or infants that present with the pneumonia. You can take time to look at them so that you may appreciate how chest indrawing is. And also, same applies with this picture, where you may look at the nose the way to show during when you talk about nasal flailing as one of the classical signs and symptoms of pneumonia. So let us first tackle very severe pneumonia. Okay, so in very severe pneumonia, the presentation is that they will present with cough or very difficult in breathing. Okay, in exemption of that, they also present with what we call the danger signs. These danger signs may be the newborn may be born with the rapid respirations that are greater or equal to 60 respirations per minute. Also, they may present in form of respiratory distress syndrome. Also, they may come with convulsions, or they may be lethargic. Above all, they may present with signs of central cyanosis. If not signs of central cyanosis, they may also be, they will present with vomiting every time they try to feed. So let us look at the signs of respiratory distress and other signs. Okay, so once you notice the following, it is very important for you to know that these are signs of respiratory distress. Among them all, you find that there will be lower chest wall indrawing. If you can go back to the previous slides, you will see the presentation of chest indrawing together with the nasal flaring. Together, they'll present with tachypnea, which is fast breathing. But once you do an auscultation here, you will find that there will be decreased breath sounds. In exemption of decreased breath sounds, these are accompanied with the crackles and the bronchial breath sounds that are present during auscultation. So, if there is consolidation in lung consolidation in particular, you find that the vocal resonance and the tactile parameters, there will be an increase in them. Okay. Also, if there is poor effusion, what happens is that the vocal parameters, resonance, tactile parameters, and the vocal resonance, these will also do what? They will decrease. So, we will also continue with the severe pneumonia. So, this cough, as I said, that it presents with a lot of danger signs. So these are the signs that we've already talked about. But also we should consider to check very severe signs. So you check that there are no signs of very severe pneumonia, such as general danger signs, things that have to be noted and should be kept on the fingerprint. So let us look at common cold or tua oxu rumen. Okay, these are not more threatening because they are self-limited viral infections that only require supportive care. And we know that in these forms, antibiotics should not be given. So in the ranges of 2 weeks, you find that these signs and symptoms of common cold, they may subside on their own. But these are neonates or children that will present with fever, wheezing, which may occur in young children, mouth, they will be using their mouth for breathing, there will be nasal discharge and cough. And what you should know that in common cold, the following are absent. Things like general danger signs that we looked at for severe pneumonia, stridor when the child is at calm, though these things are absent, and fast breathing is absent. Below there is a table that differentiates very severe pneumonia, and pneumonia as a normal with cough or common cold that is there. So we know that in very severe pneumonia, there will be cough and respiratory distress that is present. Also, you find that there's presence of central cyanosis with the subcostal recession. There will be tachypnea, which is rapid respiration. And in these patients that present with very severe pneumonia, they don't eat or drink, which means there's also loss of appetite and there's a presence of nasal flaring. They will also present with convulsions, they'll be lethargic and loss of normal levels of consciousness as well as grunting. There will be severe respiratory distress and also fever. So once you've come in contact as a clinician with the patient that has presented with these signs that I've talked about, it is easy for you to make a diagnosis of very severe pneumonia. Okay? So, which means there will be a very urgent intervention that is needed to come in. Let us also now look at the presenting signs of severe pneumonia. But one thing that we should know that in all these patients that are having pneumonia, depending whether it's very severe, is severe pneumonia and pneumonia common cold, one common thing that is present is cough, respiratory distress, and fever. These are the main centers that are present in all the forms of pneumonia. So in very severe pneumonia, what you find is that there will be cough and respiratory distress. There will be subcostal recession and with rapid respiration. But in severe pneumonia, also there is nasal flaring and grunting. But there is an absence of respiratory distress. In pneumonia, we find that there will be cough and respiratory distress with rapid respiration. But there's an absence of things like nasal flaring, convulsions, grunting, and even severe respiratory distress. In cold and cough, with something that we said it subsides on its own, you find that there will be rhinitis and respiration through the mouth, which means here they'll be breathing using the mouth. So important laboratory investigations that are supposed to be done, the first thing that we do is a full blood count. Our focus on this hemogram of the full blood count is we are looking at the WBCs, the white blood cell count. So you find that in here, there will be an increase in the ranges of 1,500 to 2,500 cells, okay, per millimeter. Also, you find that the hemoglobin levels here, they will be normal or they may be slightly low. So it's a 50-50 thing, it's not always. You can also do urine for microscopies, also whereby the focus, you can do the culture and sensitivity, because we know that there are other differential conditions that may present in the same way. The topic that we'll look at the next time that we'll have a discussion as we talk about tuberculosis. So we can also do culture and sensitivity, where we do the sputum, throat swab, nasopharyngeal aspirates, also through pleural fluid and blood to route bacteria. We may also do a chest X-ray, which is often or not specific with it. But the instance also is try to rule out other possible conditions that may be associated with something that may present as same as pneumonia. Okay? So it also cause it helps to find other causative agents. Okay? So however, The presentation of pneumococci, it may be shown on the X-ray either to be lobar or it can be lobular infiltration form of pneumonia. In aerial streptococcus infections, chest ray, it will show diffuse bronchopneumonia, which will show forms of large pleural effusion. Okay, but also something that you would see, there will be hilary lymphadenopathy that will be present as you look at the chest X-ray. Also, pneumatocells may be present. Okay, so but if it's staphylococci, you find that there is a presence of around infiltrations and pneumatocells, where you may also find the pro-infections and the empyema. So below there are examples of chest X-rays that I've put for you so that you may look at them and nicely appreciate. So the first one there, you can see the type of pneumonia that is there. Remember in our introduction we said we define them according to their anatomic position. So that is the type of lobar pneumonia of the right lower zone, okay, which even shows a consolidation there. The other one there is a form of staphylococcal pneumonia, which showing nicely the pneumatocells on the right side of the illustration there, and an abscess with an air-filled level with left side of relaxation there. So we know that despite all the signs and symptoms that have been highlighted there are still other conditions that may present the same. These are what we call as differential diagnosis. That's why in our investigations we go a little broad so that we may rule out other causes of diseases that may present the same as pneumonia. Examples of these common differential diagnosis may talk about tuberculosis, meningitis, and something that we've talked about, acute abdomen, can be bronchiolitis, it may be asthma. They can present also a form of tuberculosis. But we know that pneumonia has its own complications, and these complications can be classified into two parts. They can either be local complications, which means affecting the specific area, or also there may be systemic complications, which means a lot of organs of the body are affected. To talk about the local complications, you may talk about pneumatococcus, okay? So when you talk about pneumatococcus, this is where there will be thin-walled air, okay, on the lungs, air-filled cysts of the lung, which occurs with the empyema. Okay, we may talk about pro-effusion. Okay, when you talk about pro-effusion, this is basically where we find that there will be accumulation of fluid in the spaces, which comes in as a result of the inflammation that occurs. Okay, you may find that there will be formation of lung abscess, which there will be, you find that in the lungs, the pus will collect. Also, there will be empyema. So empyema, most you find that this is found on the pleural spaces. Okay, so you can differentiate empyema from lung abscess. Find that the pus that is found on the pleural spaces is what would make us call empyema. And when the pus is collected in the in the lungs, this is what we say it's a lung abscess. But to go to systemic complications, there are things that we call like respiratory failure, otitis, septic arthritis, peritonitis, endocarditis. A lot of things that will come about when you think about it in the broader ranges of systematic effects. Let us look at the treatment. Something very important, something that we should consider. On admission, we should know that all young infants that are lesser than 30 days, whether it's severe or it's very severe pneumonia or it's just pneumonia, they must be admitted. Okay? But the things like common cold like that, those they can be treated from home, because you know that these will resolve on their own. When you go at the medical treatment, there antibiotics. We'll give them penicillin, gentamicin. Also, we can add chlorphenical, add IM or IV, depending on the severity. Let us look at the treatment of pneumonia, which is non-severe. So you treat the child as an outpatient. When you talk about an outpatient, which means when they just come, we give medication. This is what they are treated at home. So we'll give them amoxicillin 25 milligrams per kg TDS for 3 days, 5 days, sorry. We also give erythromycin if mycoplasma or chlamydia is suspected. Okay? Okay, so you give the first dose at the clinic and teach the mother how to give the other doses at home. Okay, so there is a table there on the criteria for admission. So if you look at the sign or symptom there, central cyanosis classification, we know that this is very severe pneumonia, and what you do is we admit to hospital. When there is very severe respiratory distress, e.g. nodding and unable to drink there, we also do recommended antibiotic therapy. We'll give oxygen and manage the airway. You treat the fever if it is present, but it's something that is always present. You treat the fever. If there are signs of chest indrawing, this is a form of severe pneumonia. So you can, if you look at the table, it has been nicely been divided on the signs that will give you an indication and say this is a very severe pneumonia, and the management that is supposed to be done is on the right side. Okay, so the second part there, this is severe pneumonia, and if you look at it, you know that they'll present with chest indrawing. You admit to hospital also, you give recommended antibiotics, the antibiotics that I talked about as I was introducing the management. Also, if it's just pneumonia, you look at those parameters that have nicely highlighted there. Fast breathing, which is lesser than 60 breaths in a minute, or a child who is less than 2 months, those with greater or equal to 50 breaths per minute in a child aged 2 to 11 months. So if it's just pneumonia like this, what to do this, we treat them, these are the ones we also treat as outpatients. We give appropriate antibiotics for 5 days. I talked about erythromycin there. Okay? You slit the throat, you relieve cough with the safe remedies. Okay, so you ensure that you do a follow-up in 2 days time after administering of antibiotics, because these are the ones that we treat as outpatients. Okay? For those that will present with no signs of pneumonia or severe pneumonia, no pneumonia, cough or cold, these are also patients that will treat with what? Outpatients. So, if you would want more further things, you want to further study, you can look at our pocket book for pediatrics. You nicely find all these managements. Let us look at the treatment now for severe pneumonia. So if what we are dealing with is severe pneumonia, if you looked at the previous tables that I gave you there, I have nicely classified them with the signs and symptoms that will make you understand to say, this is the pneumonia, this is severe pneumonia, or this is very severe pneumonia. If with those signs and symptoms that have been presented there are what the patient or the child has presented with, these are the ones that will give benzopenicillin 50,000 to 100,000 units per kg IM for at least 3 days every 6 hours. When there is improvement with close monitoring of this child, you switch from benzopenicillin to amoxicillin, 25 milligrams per kg BD a day. So, which gives us a total cost of 5 days. 3 will go with the IM medication, benzopenicillin. When there's change in the next 2 days, we'll switch to oral amoxicillin. If this child does not improve within 48 hours, or the condition seems to deteriorate, you look for complications and you treat them accordingly. But if you've noticed that you've made a good assessment and there are no any apparent complications that you can see, this is the time you make a decision to switch to chlorphenical. And chlorphenical you give 25 milligrams per kg every 8 hours, IM or IV, until you've noticed that the child has improved. And then you continue with it until 10 days. But let us also look at now the therapy for very severe pneumonia. So these will give ampicillin 50 milligrams per kg IM every 6 hours, and gentamicin 7.5 milligrams per kg IM OD for 5 days. You complete this treatment with the oral amoxicillin 15 milligrams per kg TDS plus IM gentamicin OD for 5 days. Alternatively, give chloramphenicol 25 milligrams per kg IM or IV in every 8 hours until the child has improved. Then you continue with the oral, 4 times a day for a total course of 10 days. You can also make use of ceftriaxone 80 if you don't have chloramphenicol or any of these medicine. You can use ceftriaxone, which will give OD IV 80 milligrams per kg. So if you've made an assessment and we've seen that within 48 hours as well, there is no improvement, we switch to gentamicin 7.5 milligrams per kg IMOD with a combination of chlorzoxamine 50 milligrams per kg IM or IV every 6 hours. As for streptococcal pneumonia, when the child improves, you continue on with the chlorzoxamine or dicloxacillin, 4 times a day for a total course of 3 weeks. But we also have supportive therapy. So supportive therapy, this is whereby you know that there may be a presence of grunting, also signs of respiratory distress. So we'll give 1 to 3 liters of oxygen therapy. Also, you maintain good maintenance of hydration using a nasogastric tube or intra-IV line. You ensure that you control the temperature because you know that these are patients that will present with the fevers. You also give oxygen to children with very severe pneumonia, where pulse oximetry is available. So once you look on the pulse oximeter, you give oxygen to those that are saturating less than 90 degrees. We know that every normal human being, the normal saturation should be 100%. So one thing that is important that you should know is that if face mask or head masks are not recommended in this very severe pneumonia. Okay? So you continue with oxygen until all signs of hypoxia, such as severe lower chest indrawing. So for you, you will have to, when you are giving oxygen therapy, ensure that all these signs of hypoxia, things like chest indrawing, and if you look at the respiration rate of greater or equal to 70 minutes, they are not present. We know that these patients now, they are stabilizing. You discontinue the oxygen if the saturation remains stable and above 90%. So we do a close monitoring of 3 hours. Also, we should ensure that catheters are not blocked with mucus, or then they are properly inserted and functioning. So it is best recommended for these with severe pneumonia to use nasopharyngeal catheters and nasal catheter. So the reason why we do a 3-hour close monitoring, because we know that these may be presenting with a mucus, so we are scared that there will be blockage on the catheters. Let us look at pneumococcal pneumonia, which is the most common cause of bacterial pneumonia in childhood. And the most attacking rates, it occurs in the first 4 years of life. Okay? So the effect here, you may find that it can be one part of the lobe or all the lobes are involved. Okay? But the more common presentation, if you look at it in infants, is it's more in patchy, and the diffusion is on the bronchioles that you see it. Okay? So it has stages. The first stage, you find that they'll start with congestion, and this congestion can also be in the form of edema. Okay, once there's congestion that has occurred there, it will advance to the next stage. Okay, this is a stage where we call as red hepatization. Okay, so in this second stage, what is happening is that the alveoli now is being filled within the fluid, edema, the red cells, and the fibrin. So it is very important to understand what is the pathophysiology that is occurring, because this will occur in 4 stages. The first stage, which we will start with, is the congestion. As the congestion progresses, it advances to a red hepatization stage, where now the alveoli is now being occupied or filled with the fibrin and the edema fluid. They will advance to the gray hepatization deposition. Okay, so this is where now all the fibrin over the pleural spaces, the alveolar spaces are filled now with the fibrin and the PMNS. Okay, so what is happening in the gray hepatization is that phagocytosis is rapidly taking place in there. The last stage now is the resolution. Okay, so as a result of increase of the phagocytosis that is occurring in the gray hepatization now, there will be increased phagocytic activity, which means that there will be generation of the neutrophils, the fibrin thread, and all the remaining bacteria now they are digested. Okay, the clinical crisis will occur without treatment about 7 days of the illness, because of the pathogenesis that is occurring there in the 4 stages. Because we know that in the last stage now, because of the phagocytosis, everything is being liquefied. And we expect a complete resolution expansion in between 1 to 3 weeks. Another form of pneumonia is staphylococcal pneumonia. This is suggested if there is rapid clinical deterioration despite treatment. Okay, if you look at the chest X-ray this way, you may find that there will be a pneumothorax or pneumatocells. So if you see these things on an X-ray and you've seen that you've been treating this infant, but there is still a rapid increase of deterioration and there's no improvement, it is important for you to start thinking of it being staphylococcal pneumonia. Okay, so if you do the cultures there, you find that there will be gram-positive cocci on the smear of sputum. There is a heavy growth of staphylococcus aureus, or you may also find that there will be empyema fluid. Also, what supports the diagnosis is the skin pustules. Treatment, you treat with chlorzoxamine 50 milligrams per kg IM or IV for every 6 hours. You also add gentamicin 7.5 milligrams per kg IM OD. When the child improves, you continue with chlorzoxamine orally 4 times a day for a total course of 3 weeks. One thing that you should know is that chlorzoxamine can be substituted by any other staphylococcal antibiotic. You may talk about things like doxycycline, flucloxacillin, or oxacillin. Let us look at empyema. Okay, you can make a diagnosis of empyema when a child presents with severe pneumonia or develops pro-effusion. When you do an examination, basically when you do percussion, you find that there will be what you call as a stony dow sound that comes. Okay, and this you can compare it with the side of the chest that is okay, and the one that is affected. So on the affected side, when you do a percussion, there will be what you call a stony down sound. If you do a pro-rab, you may be heard on an early stage before the effusion is fully developed. Okay, when you do a chest X-ray, you find that there will be fluid levels both sides of the chest. Okay, so what you should notice is that when empyema is present, whether you give antibiotic therapy and antibiotic therapy, the fluid is cloudy or frankly prurient. So the treatment of empyema is we'll do drainage because you know that because of the pro-effusion that is present, we should drain it unless otherwise it is very small, which means it can resolve on its own. If effusions are present on both sides of the chest, we do bilateral draining of the fluid. Okay, so it becomes necessary to drain 2-3 times because fluid sometimes it has a tendency of retaining. When they go cut. should be cutting. Okay. So the treatment there is very simple. Subsequent management depends on characteristics of fluid obtained. Where possible, the profile should be analyzed for protein and glucose content. Also, because we would want to look at the cell count and the differential count and examined after a gram, Nelson staining. So thank you so much, Mlakoze Danke, for watching and paying attention to this tutorial.